And he has built a very robust program that we're all very proud of, has the opportunity for our patients who live on that side to come closer and be able to get the benefit of an academic program under his supervision. So today he's going to talk about, in my opinion, what is probably one of the most difficult lymphomas to treat, because there's not one right answer. So we hope to get more insights from Dr. Jasem. And without further ado, I'm going to hand over the podium to him. Dr. Jasem, please move forward. Take care.
Thanks, Dr. Kamda. Thanks for this nice introduction. And thanks for your great leadership. And I'm trying to share my, yeah, there you go. I don't know if you guys see my slides or not, but do you guys see it?
Yes.
Great. So as Manali said, this is really one of the most challenging types of lymphomas to treat. There are new prospects about its treatment management that are very exciting, but still it's one of the most challenging lymphomas when it comes to the clinical treatment and management. So according to the WHO classification, I first apologize. I have a really bad flu for the last couple of days. So I've been drinking a lot of water and maybe coughing, so I apologize for that. But mantle cell lymphoma, according to the WHO classification of 2016, is a mature B-cell neoplasm. And we usually, although not very, scientifically accurate, but for descriptive purposes, we usually classify lymphomas into three main categories, especially for our patients. We tell them we have 70 different types of lymphomas that we classify into three main categories: high-grade lymphomas, low-grade lymphomas, and intermediate-grade lymphomas. High-grade lymphomas like diffuse large B-cell lymphoma are aggressive type of lymphoma that need to be treated promptly within days to weeks. But the good thing about them is that you can potentially cure up to maybe 60% of those cases, even if they are advanced stage. For example, advanced stage breast cancer is incurable, but advanced stage lymphomas can have a significant cure rate and durable remissions for years. On the other hand, low-grade lymphomas, we tell them that they're indolent, they're very slow growing, but they're incurable, which is the bad thing about them. So I usually tell my patients, think about it as if you have a chronic disease like high blood pressure and diabetes. We can treat you adequately if needed, but we cannot eradicate it or cure it. We classically put mantle cell in between, in that intermediate group between these two different extremes. But really, when it comes to the clinical heterogeneity and the clinical presentation, natural history is more akin to the aggressive type of lymphomas. So if it's a spectrum, it's really more on this side of the spectrum than the low-grade side of the spectrum. And unfortunately, it combines the bad traits of both the high-grade lymphomas and the low-grade lymphomas. It's aggressive like high-grade lymphomas, yet incurable like low-grade lymphomas, which makes it really challenging. And that's probably why a lot of even community oncologists try not to deal with mantle cell directly. It's really tricky to treat. The concept was first introduced by Dr. Dennis Weisenberger in 1984 as a pathologist. I think at that time he was at UC Davis. And then we briefly worked together at UNMC, University of Nebraska Medical Center. I was still a student. He's an exceptional man. He described it as a variant of intermediate lymphocyte lymphoma or lymphocytic lymphoma that proliferates around mantles or in mantles around non-neoplastic appearing germinal centers. Hence the name mantle cell lymphoma. This lymphoma is confined to the mantle zones of the lymphoid follicles and usually keeping the germinal centers intact. It is a rare disease that accounts for about 5% of adult non-Hodgkin lymphomas, about 5 cases per million per year or annually in the US. There is a male predominance, male to female ratio is 3:1, white to black ratio is 2:1. And it's typically a disease of the elderly with a median age of diagnosis or at diagnosis of 68 years. The main genetic culprit or lesion in mantle cell is translocation 11;14. There's balanced reciprocal translocation between the long arm of chromosome 11 and the long arm of chromosome 14, which juxtaposes cyclin D1 gene locus on the long arm of chromosome 11 to the immunoglobulin heavy chain locus on the long arm of chromosome 14. And that results in the constitutive expression of cyclin D1, a protein that's not normally expressed in mature B cells. and it regulates or dysregulates actually the cell cycle, imparting a survival advantage to that clone of the B cells. How it exactly does that is believed that the prime mechanism is that overly expressed cyclin D1 protein binds to the cyclin-dependent kinase 4, forming a complex of D1 CDK4. And as the name implies, kinases usually phosphorylate substrates in the cells. So that kinase phosphorylates the RB1 protein, which is one of the important oncosuppressors in the cells. We call the peritoblastoma 1 protein, which is a product of peritoblastoma 1 gene, which is normally combined to E2F. But once it's phosphorylated, that complex dissociates, releasing E2F, which is a transcription factor that enhances the transition of the B cells from the G1 phase of the cell cycle, which is the resting phase of the cell cycle, to the synthetic phase of the cell cycle, which happens before mitosis or precedes the process of mitosis. So obviously, this is a clear proliferative advantage to the cells in the vast majority of mantle cell cases, owing to that translocation 1114. In less than 5% of cases, that translocation is not there and cyclin D1 is negative, but those cells tend to have a higher content of cyclin D2 and D3. So it looks like the process is somehow cyclin D dependent in a way. Although this is an important process for the tumorigenesis of mantle cell, but it's not the only lesion that happens. There are normal cells that B cells that contain that translocation 1114, but they do not progress to become mantle cell lymphoma. So this might be an important step, but it's not the only step. There are other changes that happen. There are other mutations that accumulate with time, resulting in the initiation of mantle cell or the actual disease initiation and progression, including genes that are involved in genomic stability, like TP53 mutation, ITM mutation, also mechanisms that resist apoptosis, like BCL2, Notch1, Notch2 mutations, interactions with the microenvironment, like BCR and PI3K and mTOR pathway activation and protein-derived growth factor alpha, and there are even epigenetic factors that are implicated in the pathogenesis of mantle cell lymphoma. So where exactly it happens, we believe that lymphomas represent the malignant counterparts of lymphocytes arrested at certain stages of maturation. So for each lymphoma, supposedly we have a normal counterpart. So normally, as we know, that the B cell lineage starts or production starts in the bone marrow, which is antigen independent, from pro-B cells to pre-B cells to mature B cells that are naive, not antigen experienced yet, that leave the bone marrow to the peripheral blood and thence to the lymphoid tissues, primary and secondary lymphoid follicles, where they encounter the antigens and undergo what's called antigen-dependent B cell differentiation, with diversification of the immunoglobulin heavy chains and the formation of what we call maturity, affinity maturation, and somatic hypermutation. That results in the differentiation of the B cells to either plasma cells or memory B cells for future encounters with the foreign antigens. Where exactly that mutation happens or that translocation happens is believed to happen in the pre-B stage in mantle cells. So it's basically in the bone marrow. So if this is a cell that harbors translocation 1114, then that leaves, the pre-B cell leaves the bone marrow as a naive B cell, and they gets into the mantle zone of the lymphoid follicles. The majority of those cells will stay in the mantle zone, about 80% of them, and they don't move forward like the normal counterparts to the germinal centers. So they don't undergo that process of affinity maturation and somatic hypermutation. They have unmutated IgHV status, and they also express a special protein or transcription factor known as SOX11. SOX11 is normally found in human beings. It's actually a part of the SRY box of transcription factors or genes that encode for transcription factors required for cell differentiation, especially the process of neurulation, neural tube formation from notochord in the embryonic life. But expressing that cell in the B lineage in mantle cell seems to act the exact opposite. It blocks differentiation rather than enhances differentiation. So it's really an oncogene in case of mantle cell. It's believed to block differentiation via down-regulating PAX5, which is required for B cell commitment and maturation. So those cells cannot differentiate. As we know, we have the cell cycle for cell division, then it's followed by cell growth and then differentiation. So TIF1114 will enhance cell growth, and SOX11 seems to block the other step of growth and maturation, as well as it prevents those cells from getting into the germinal centers via blocking the BCL6, one of the important germinal center markers. And so it stays in the mantle zone. And more importantly, it also enhances the expression of platelet-derived growth factor alpha and beta, which enhances angiogenesis and the microenvironment interaction between those cells and the stroma of the lymphoid follicles, which enhances the spread of those this clone of B cells to the lymph nodes and also some extranodal tissues, especially the GI tract. And this is exactly why we have mantle cell, we call it classic mantle cell lymphoma. Only a few of those, or a small subset of those cells, about 20% of them will go to the germinal center, like the normal counterparts, where they undergo somatic hypermutation. They lost SOX11, and they follow more of a path similar to that of the normal counterparts. We call them non-nodal. They have a predilection to accumulate in the blood and the spleen, and we sometimes call it leukemic type of MCL. Although the name implies an aggressive type of disease, but really the leukemic variant is more indolent than the classic MCL. But both of them are highly genetically unstable, both subtypes, both origins of MCL, and they can undergo future mutations, which can result in progressive disease and blastoid formation with very aggressive clinical course. About 70% of cases present at an advanced stage of diagnosis. Majority are nodal disease, as we discussed. Disease can involve the lymph node, the spleen, the bone marrow, peripheral blood, GI tract, and rarely other tissues like the breast, pleura, orbits, and CNS. And B symptoms are present about 30% of cases at presentation. The usual investigations that we do for lymphomas, like CBC with differentials, to look at the burden of disease and the impact of mantle cell on the other normal lineages of hematopoiesis, namely the red cells and the platelets. CMP to evaluate for the liver function, renal function, electrolyte changes, in the setting of tumor lysis. LDH also, more LDH is usually associated with more aggressive disease as well as more risk for tumor lysis. Uric acid, hepatitis B serology, because more likely we will give a regimen that contains rituximab that can activate hepatitis B. We do biopsies. We do PET scan for staging, bone marrow biopsy, lymph node biopsy for staging and diagnosis, obviously. We do LPs, especially if patients have CNS symptoms or in the blastoid variant, which has a special predilection to the CNS. And we do EGD colonoscopy in patients who have GI symptoms, or if they have early stage disease. Let's say a patient comes to me with a cervical lymph node enlargement that's proven by biopsy to be due to mantle cell, and we are thinking about a milder form of treatment like radiation. It's probably prudent to do an upper and lower endoscopy to rule out the involvement of the GI tract with the mantle cell, because that will upgrade the stage of disease and obviously change the management. Peripheral smear in the leukemic variant, especially, you see those intermediate sized lymphocytes. The normal lymphocytes, as we know, are the size of the adjacent red cells. These are bigger, that have a high NC ratio with cleaved nucleus and dense chromatin, inconspicuous nucleoli. So these are the usual features of mantle cell. If you take biopsies, we see the exact population of small to intermediate sized cells invading either the entire lymph node or tissue specimen with complete effacement of the and loss of the architecture of the specimen. There's a diffuse type, or sometimes they form nodules with relative sparing of the islands between these nodules, or sometimes we have even polymorphic and blastoid features. Immunohistochemistry is very important for diagnosis. The immunophenotype classically, mantle cell expresses the pan B cell markers of CD19, CD20, CD22, CD79, A and B. Actually, they are parts of the BCR receptor, but also characteristically, they tend to express one of the immature markers of B cells, namely CD5 positivity, and it's actually more of a T cell marker, ideally, and also they express both surface immunoglobulin M and D, which, as we know, this is a very kind of unique process to the and peculiar to the naive B cells in the mantle zones, even normally, because in the bone marrow the B cells tend to express more of IgM, and then when they get into that mantle zone, they express both, which is a very intriguing phenomenon. And then when they get into the gemellar centers, they tend to lose the IgD and express more of IgM. So mantle cell, just like their normal counterparts, express both. And they're usually negative for the gemellar center markers like CD10 and BCL6, and also negative for classically for CD23, which helps differentiate between mantle cell and CLL, for example. Rarely we have mantle cell that's CD5 negative, CD23 positive. For unknown reasons, 80% of cases are lambda restricted. And also in the GI, they tend to express CD49D, which is an integrin that helps the attachment of those mantle cells to the stroma of the lymphoid follicles within the lamina propria and the submucosa of the GI tract. Cyclin D is very helpful to differentiate between especially mantle cell and atypical CLL that's expressed in more than 95% of cases. SOX11 is also very important because especially in cyclin D1 negative cases to confirm diagnosis. We also are very interested to know the Ki67 as a proliferation index because we classically consider cases that have a Ki67 of less than 30% to have more favorable outcomes. Genetics, as we mentioned, the hallmark is translocation 1114. The disease is IGHV non-mutated in 80% of cases, but unlike CLL, that doesn't seem to have any prognostic significance. But the mutations that do have prognostic significance include TP53 mutations, 7TP deletions, c-MYC translocation, and Notch1 mutation. In general, contrary to the routine old way of just looking at the routine histology, adding those CD markers, cyclin D1 staining, SOX11, FISH for translocation 1114, can reliably lead us to a diagnosis of MCL with less inter-observer variability and better inter-observer concordance. So that's why in almost all cases we can make the diagnosis of MCL, even if one of those markers, none of them is perfect, but even if one is negative, the other one is usually positive anyways. Regarding treatment, it's important to tell our patients I usually tell them from the first session that the current modalities are not curative. We cannot eradicate it, but we can help you, we can treat you adequately. And we classify treatment modalities into initial treatment, upfront treatment, and also treatment in the setting of relapsed refractory disease. The initial treatment include three stages: stage of induction, consolidation, maintenance, which is more reminiscent of the way we treat acute leukemias rather than standard lymphoma treatment. And we have a number of aggressive and less aggressive regimens that we can use. There's really no consensus on which one to be used. A lot of our decisions are based on patient, physician preferences, experience with those different types of regimens. Sometimes, a lot of times, it depends on transplant eligibility. If the patients are young and fit, we usually tend to give them aggressive induction regimens and then followed by auto transplant, then maintenance. This is the standard of care. For patients who are otherwise old, frail, transplant ineligible, we tend to give them less aggressive treatments and sequentially give them more treatments as needed. And also, importantly, the TP53 mutation status has a huge impact on treatment because really, for those cases, the best way to treat them is to enroll them in a clinical trial. None of those aggressive and less aggressive measures are of particular really efficacy or high efficacy in the setting of TP53 mutation. Except for stage 1 and sometimes stage 2, that's non-bulky and contiguous, we can consider involved site radiation therapy. Of course, if the patients are asymptomatic, we can also observe them with close follow-up every 3 to 6 months. But for stage 1, we have the option to give radiation therapy based on retrospective small studies that showed at least PFS is higher for patients who received radiation compared to no radiation. But in the vast majority of cases, as we mentioned, they present with more advanced disease. So we tend to give them for younger patients who are transplant eligible, one of the aggressive regimens, including, for example, RDHAP. It's a combination of rituximab, dexamethasone, high-dose RRT, and platinum-based chemotherapy, either oxaliplatin, carboplatin, or cisplatin. And this is extrapolated from the Lima study, a phase 3 trial that included about 300 cases of mantle cell previously untreated younger. This study was originally designed to evaluate for the efficacy of maintenance rituximab after auto transplant, but those patients received RDHAP for 4 cycles, and it showed that the RDHAP has really high overall response rates, including 77% even complete responses. Which one to use, which platinum-based chemo to use? Really, there were a few patients in the trial that didn't use oxaliplatin. They used cisplatin and carboplatin, and it looks like oxaliplatin had superior PFS and overall survival outcomes in patients who received RDHOX compared to the ones who received cisplatin and carboplatin within the RDHAP structure. And also oxaliplatin was better tolerated. So we commonly at Anschutz, we commonly use just RDHOX basically because of these data, because it's efficacy as well as relative safety compared to the other platinum-based therapies. Another option is to use RDHAP alternating with R-CHOP for 6 cycles every 21 days. And also, again, for patients who can tolerate aggressive therapy, who are transplant eligible, with a median follow-up of 6 years, it was found that time to treatment failure, which is a close surrogate to progression-free survival, was 9 years for the patients who received alternating therapies compared to just R-CHOP. So 9 years compared to versus 4 years. And there was no difference in overall survival, but that progression-free survival is highly significant. Unfortunately, as expected, that combination of R-CHOP, RDHAP is more toxic than R-CHOP alone, but treatment-related mortality was similar in both regimens, both arms, about 3.4%. There are other regimens, like the Nordic regimen that uses maxi R-CHOP with high DAC, and another one, hyper-CVAD rituximab, alternated with rituximab, high-dose rituximab, high DAC. These are very aggressive measures. For example, maxi R-CHOP uses really higher dose of Cytoxan. Instead of using 750, it uses 1200, higher dose of doxorubicin. Instead of 50, it uses 75 milligram per square meter. These are very aggressive treatments. There's no data that suggests they are superior to RDHAP or RDHAP alternating with R-CHOP. Plus, they can also affect the process of stem cell collection. And about, for example, 40% of cases that were enrolled in the original trials for hyper-CVAD couldn't continue because of toxicity. So we never use them at Anschutz. For patients who are transplant ineligible and they would like to get, or they're more eligible for less aggressive therapies, we can use R-CHOP, for example, one of the acceptable options based on phase 3 trials by the European MCL network that included about 500 cases and randomized equally to R-CHOP versus RFC with a median follow-up of 36 months. It was shown that the R-CHOP group has significantly higher overall survival. And also, more importantly, it was better tolerated than RFC, so we never use RFC anymore. R-CHOP is acceptable for patients who cannot get more aggressive therapies. Another one that we most commonly use is BR, actually. BR, bendamustine rituximab, one of the old therapies that has been present in Eastern Germany for years, but got into the western part of Germany and Europe in 1990s. The US, I think, was approved in 2007. So based on the STILL trial that included not only mantle cell, but all advanced indolent non-Hodgkin lymphomas, 500 cases, and randomized them to either receive BR on R-CHOP each 6 cycles, it was found that actually overall survival was similar in both groups, but BR to R-CHOP, patients who received BR have significantly higher PFS, almost 1 year more compared to R-CHOP. And it was also safer when it comes to the side effect profile. BR was safer than R-CHOP. They have secondary or similar second malignancy, rates of second malignancies. But one of the main criticism of this trial is that more than 50% of participants censored for different reasons. So there's another trial that also looked at BR versus R-CHOP or RCVP, so BR or CHOP-like chemotherapies, again, in about 450 cases of indolent non-Hodgkin lymphomas, including about 74 cases of MCL, with a median follow-up of 45 months. Again, there was no difference in overall survival between BR and R-CHOP or RCVP, but the PFS was, again, in favor of BR, although less dramatic than the STILL study. This is 66 versus 56%. It looks like BR caused for MCL patients more direct sensitivities and vomiting, mostly because it doesn't contain the steroid part of R-CHOP or RCVP. So I would assume that most of these direct sensitivities from rituximab itself. But of course, it caused less peripheral neuropathy, less alopecia, and there were more secondary malignancies, but most of them were skin cancers. Another exciting, I think, regimen that can be used is BR plus ibrutinib, and this is based on the SHINE trial, a recent one. It's a phase 3 trial that got published in 2022 that included more than 500 cases of treatment-naive MCL patients, again, that are transplant ineligible, and they either received randomized equal to either receive BR or BR plus ibrutinib. So this is the first one is BR plus placebo, the other is BR plus ibrutinib, and then the ones both groups got either ibrutinib or placebo maintenance plus rituximab maintenance every 8 weeks for up to 12 infusions with a long follow-up of about 7 years. It was found that overall survival was not different, but there's a very clear difference in the PFS. PFS, you can see for BRI is 81 months versus 53 months for BR. So more than 2 years difference. And the side effect profile, as expected, the ibrutinib group had more AFib and pneumonias, but really the treatment-related mortality was similar in both arms. Then comes the question, is it worth it? Like if the overall survival is similar, is it worth paying about $150,000 to $200,000 every year for ibrutinib maintenance? Is that financial toxicity? Does it justify basically giving ibrutinib or adding ibrutinib to improve progression-free survival? So as we will also discuss with rituximab maintenance, there's a debate over that as well. When it comes, for example, to low-grade lymphomas, let's say, follicular lymphoma, I really give both options to my patients and whether to give maintenance or not. But I am in favor of not getting maintenance because really, even if those patients relapse, follicular lymphoma relapses in most cases is still mild, and we still follow these patients for maybe year 2, 3 before needing treatment, before meeting the active disease criteria. But it's not the same. The concept of PFS is not the same when it comes to mantle cell. If the mantle cell patients relapse, we tend to treat them aggressively. So I think then over 2 years, 2.5 years of disease being disease-free in mantle cell, I think it's worthwhile. Otherwise, if they relapse earlier, they would end up, using more treatments. And again, I think eventually the financial toxicity will be the same. Another concern is if those patients get ibrutinib frontline, they might not be able to get any, or they will not for now at least, get those BTKIs as second-line therapies. Yeah, that's still a concern. But again, we have now a new trial that's looking at pirtobrutinib compared to the standard of care BTKI. That's the BROIN 321 trial that will likely end with approving pirtobrutinib for second-line treatment anyways, including for patients, or specifically for patients who failed previous BTKIs. So I think that shouldn't be a concern. For me, I would obviously explain to the patients, I would give them both options, but I would be in favor of using ibrutinib, especially that those patients don't have great options. They're the ones who are transplant eligible and they're older. So I think it's reasonable to give ibrutinib added to BR. This regimen is VR-CAP that incorporates Velcade or bortezomib instead of doxorubicin. It's really not less aggressive as we claim to be. It has a lot of side effects, and we don't usually use it anymore. So I've never used it. Another acceptable option is BRAC, so adding some RRC to the BR. And this is, again, for elderly patients who are transplant eligible. It's an acceptable option. It has high overall response rates and high 2-year PFS. R-square with lenalidomide and rituximab is another acceptable option for those patients. So it's terrible. Whatever I got is really not good. So then this is the phase of induction. On consolidation, the standard of care is to use autotransplant based on numerous studies, including some older, about 20 years ago, studies of a limited number of patients that received high autotransplant after aggressive induction regimens and showed relatively high overall survival in 5 years and disease-free survival rates. Especially the MD Anderson trial showed that improved outcomes were observed for the patients who had lower beta-2 microglobulin. Also in Australia, another small study that looked at autotransplant after hyper-CVAD showed at 3 years that overall survival and event-free survivals were close to 92-93%. And then there are bigger studies, including looking at the European MCL study that looked at autotransplant versus interferon alpha. These two groups have similar overall survival, but PFS was significantly higher for the patients who received autotransplant compared to the ones who received interferon alpha. So then, of course, autotransplant became a standard of care, and all the previous studies we mentioned, like Lima study and others, still take all those patients when they are in complete remission into transplant. So then comes the idea of maintenance therapy, to give rituximab maintenance or not. There are numerous studies. We have looked at rituximab maintenance after R-CHOP and RFC versus interferon maintenance, and it was found that actually rituximab maintenance was not beneficial after if FCR or FRC, but it was beneficial after R-CHOP. As we can see, there is an increase or improvement in both overall survival and PFS in those cases who received rituximab maintenance following R-CHOP. After BR, there is debate. The subsequent analysis of or subgroup analysis of the STILL trial showed really patients who received rituximab maintenance versus observation did not have a significant survival advantage. But a more recent real-world database that involved about 1,600 cases showed that really adding rituximab maintenance to both R-CHOP and BR has a significant PFS advantage, as well as overall survival advantage. As we can tell, this is the R-CHOP plus MR, BR plus MR versus the ones that received BR and R-CHOP without MR. The time to next treatment, as well as the overall survival, is significantly higher for rituximab maintenance. Rituximab after RDHAB, do we give it or not? The Lima trial, as we discussed before, did take 257 patients to transplant and then randomize them to either receive rituximab maintenance or observation. With a median follow-up of 50 months, initially it was found that clearly, again, EFS, event-free survival, was higher for the rituximab maintenance group, and also PFS was higher for that group. OS was higher for the rituximab group, but only a shy increase by 9%, 89 versus 80%. But follow-up study recently that discussed at ASCO 2023 showed actually after 7 years, The differences in EFS and PFS were maintained, but the OS is no longer significant, overall survival. And more importantly, that rituximab maintenance did not increase risk of infection during or mortality from infections. So it's safe, basically. We can give it as an option to our patients, but to me, again, PFS, the concept of PFS for mantle cell is different from low-grade lymphomas like follicular lymphoma and mantle zone or marginal zone lymphoma. So to me, I think if we can keep our patients anxiety-free and as anxiety-free for a long period of time by giving rituximab, it's worth doing it. Especially now, we'll discuss later on that rituximab maintenance was also incorporated in some other likely practice-changing trials. So most of that discussion, or all of it, applies to TP53 unmutated or wild-type disease. The mutated one, as we said, the treatment is unknown. The best is to incorporate them into clinical trials, however, with time. For younger fit patients, it's reasonable to give them more aggressive therapy. For older, it's reasonable to give them less aggressive therapy. Although some people say, well, they're not going to benefit from therapy anyway, so we might as well give all of them low-intensity therapy. So it's really, it depends on the patient preferences, patient values, and physician preferences a lot of times. But in general, taking those patients to consolidation with oral transplant, studies have shown, this is from the Nordic studies of oral transplant, they have shown that patients who have TP53 mutation disease have really bad outcomes. They have grave consequences after the, or at least the natural history is not affected, let's put it that way, by the oral transplant. As we can say that for patients who have wild TP53 status, the median overall survival is 12.7 years, versus for the ones who are TP53 mutated, it's only 1.8 years, so even less than 2 years. And 50% of those patients relapse within 1 year of transplant. And it was also found that TP53 mutation status, just like other adverse features like, KI more than 30% or blastoid variants, they all have worse outcomes after auto transplant. But unlike the other two, being mutated for TP53 mutation or gene is considered to be independently associated with worse outcomes, survival outcomes following auto transplant. So we don't classically or typically do auto transplant for those patients. It's reasonable to do allo transplant for a subset of patients that are really young and can tolerate it. But again, this is limited by really high non-relapse mortality from transplant. It's 20%. Sometimes we tell our patients, we had one of my mentors used to tell patients, if I do an open heart surgery for you, risk of death is 1%. If I do an allo transplant, it's 20%. It's 20 times more aggressive. But it's the only potential cure, especially for TP53 mutated cases. And also, it has been shown that the post-allo outcomes, survival outcomes, were not affected by the TP53 mutation status. All these are all retrospective small studies, but some people interpret those as allo transplant being able to overcome the shortcomings of the auto transplant when it comes to the survival outcomes of patients with TP53 mutated disease. So this is the usual standard of care now that we use for induction and maintenance and consolidation for our mantle cell lymphoma cases. Not going to go over all of them, we already discussed them. But this is all likely to change soon with this new trial, the Triangle trial. It's a phase 3 trial that included a huge number of patients, about 870 cases of initially or of treatment-naive MCL cases that are equally divided into 3 categories. There is arm A that basically is the standard of care, R-CHOP with RD-HOP, followed by auto transplant, then observation. And all these 3 groups actually got rituximab maintenance, or were allowed to get rituximab maintenance. The second arm is adding ibrutinib to the induction chemo immunotherapy, and then followed by auto transplant, and then 2 years of ibrutinib maintenance plus rituximab maintenance. And the third one is giving that R-CHOP with RDHAP, but basically plus ibrutinib with ibrutinib maintenance and rituximab maintenance, but no auto transplant. So if you look at the outcomes are really interesting here, like the failure-free survival, for example, and the OS more pronounced in failure-free survival, as you can tell, patients who receive the standard of care of chemotherapy followed by auto transplant followed by rituximab maintenance has significantly inferior outcomes compared to the ones who received ibrutinib. And when ibrutinib was directly head-to-head compared to auto transplant, the PFS or FFS was actually 86% versus 72%. So it's clearly more efficacious than ibrutinib is more efficacious than auto transplant. And more importantly, ibrutinib seems not to increase the toxicity from chemoimmunotherapy, so it's safe, but it does increase the risk of infections after auto transplant. So really, if auto transplant is inferior to ibrutinib, it's not helping much, and adding ibrutinib to it is making it more toxic, then is there really any point of doing auto transplant anymore? To me, I think that group is winning. This group is winning that included ibrutinib without transplant, added to the induction chemotherapy with ibrutinib maintenance or rituximab maintenance, because it seems to be the most efficacious and the safest. So it's combining both qualities. I think this is going to already, for me, I have seen a couple of patients and I recommended this regimen. And although it's not published yet, people are so excited about it. Even NCCN guidelines have changed their guidelines. Now this is becoming the first-line therapy for mantle cell, including the ones who have TP53 mutation disease. For relapse disease, we have really don't have much time left, but we have a number of BTKIs, the covalent ones, like ibrutinib, acalabrutinib, zanubrutinib, all based on really phase 2 trials. So they all got accelerated approvals, and they all have reasonable outcomes, but really median overall survival after these covalent BTKIs is only 10 months, and they're not effective when given sequentially. So that led to another trial, a phase 2 trial called BROIN trial, that looked at pertobrutinib, which is a non-covalent BTKI that inhibits both the wild type and the C481, which is the most common mutation in BTKI resistance. So it looked at the initial analysis of 90 cases for those patients who received prior BTKIs showed that they have a duration of response of 22 months, median PFS of 7 months. So it's a good option for patients who failed other BTKIs and we don't have other great options for them. There are other studies that are looking at ibrutinib plus venetoclax, like this phase 2 trial that looked at 23 patients with relapsed refractory mantle cell. Most of them had TP53 mutation. Again, the CR rate were reasonable, 42% in 16 weeks. Adding again obinutuzumab to ibrutinib plus venetoclax is studied now by the OASIS study as a phase 2 trial for both untreated and relapsed refractory mantle cell lymphoma, and especially for the ones who are actually for both groups, untreated and treated, there's a very high rate of MRD negativity after even 3 cycles of treatment, as we can see here, and almost 100% of those who were untreated achieved MRD after 3 cycles, and about 70% of those who had refractory disease. And TP53 doesn't seem to affect the outcomes, although the numbers are small, but again, that's one of the options also available, perhaps soon, will be available soon for patients who have relapse disease and TP53 mutation. CAR-T, we give it now for patients who as a third-line therapy based on the ZUMA trial that included heavily pretreated mantle cell cases and led to the approval of the CAR-Ts for, as I said, third-line therapy for mantle cell lymphoma. With a median follow-up of 12 months, it was found that objective response was achieved in 93% of cases, including 67% of them had complete remission. And overall survival at 1 year was over 80%, and at PFS at 12 months was about 60% or over 60%. It's going to be interesting to see what happens with the long-term outcomes or analysis of these studies in the future, but CAR-T is a very acceptable option now for patients with relapsed refractory mantle cell. And as we discussed, allotransplant can also be an option, even for patients who are not TP53 mutated, that have multiple other relapses that are otherwise younger. Although, as we mentioned, mortality from transplant is relatively high, and survival depends on the disease status of transplantation, whether they were in CR or PR, also in remission duration after auto transplant. Usually, relapses within a year of auto transplant that undergo allo transplant have worse outcomes compared to the ones who relapsed after 12 months. Are you on time or yeah? Thank you very much. Sorry.
Really, really lovely talk. Very comprehensive, and you did a great job. I'm wondering if there are any questions in the chat box, and if there are not, maybe I'll start with one. So maybe can you comment on all of these clinical studies that are done with ibrutinib, you know, in the relapse setting, in combination, and now, of course, with the triangle study, with the SHINE data. We also do know that there has been a voluntary withdrawal of ibrutinib. So, you know, for the mantle cell lymphoma subtype. Are you comfortable extrapolating this to second generation inhibitors in the frontline space? You think we are ready for incorporating BTK inhibitors in the frontline?
I think we are. I think the data are very clear. For example, adding it to BR, although the overall survival is not different, but the PFS, I think it's really worthwhile. 2.4 years of being progression-free is worthwhile. Whether we can extrapolate that to the second generation, I wouldn't do that, because if they're not studied really, I'm more like waiting until those different combinations are studied. And I usually tend to wait. I'm more conservative than a lot of you guys till we have more data before I change my practice. But with ibrutinib, whether added to our DHAP, RCHOP, or BR, I think the outcomes are very clear and strikingly evident that there's benefit of adding ibrutinib. So I wouldn't hesitate to do that.
So in the frontline setting, I think I totally get it for the triangle study. But for the SHINE data, there was clearly a little more toxicity on the triplet, BRI versus BR alone. Do you think the toxicity is worth taking for the PFS benefit?
I think so, because otherwise they will get ibrutinib second line anyways, or acalabrutinib second line, or CAR-T, which are also very toxic. So if those patients will be, progression free for 2 or 3 years without adding ibrutinib, that makes sense. But I think adding ibrutinib with that extra toxicity of IFAP toxicity or cardiac toxicity, which is well known for ibrutinib, it's still justifiable to add it for me. The financial toxicity is still there, obviously. There's 150,000 K per year added. But again, considering that those patients will be otherwise hospitalized for CAR-T or transplant and so forth, I think it's worth doing it. The cost can eventually be the same.
And, we looked at your algorithm that you beautifully outlined for patients with mantle cell lymphoma. My question is for patients who are TP53 mutation positive, say if they're transplant ineligible and they're not really able to find a clinical trial, what is your approach for patients with newly diagnosed TP53 mutation?
Yeah, so if they are transplant ineligible, I tend to give them less aggressive therapy. I think BRAC is very acceptable. Now BRI is very acceptable with the SHINE study. So I would use one of those 2 measures. And if they relapse, maybe single agent venetoclax is studied, as we know, in the relapse setting. And it's a phase 1 study, but it showed that mantle cell cases actually had better survival with venetoclax compared to other non-Hodgkin lymphomas, about 82% in 2 years. That's an acceptable option. Venetoclax plus minus ibrutinib plus minus obinutuzumab in the relapse setting.
Right. That's the OASIS study, right, Jagar?
That's the OASIS study, yes.
It's very interesting, right? I think the practice patterns are so different, even within the US, let alone within an institution or across the world. Like, for example, for TP53 mutation, clearly there is a subset that starts off with BTK inhibition, and if they relapse, they take these patients to CAR T cell therapy. What are your thoughts on that approach?
So I would prefer CAR T over allo transplant, even for the transplant eligible ones, to be honest with you. So yes, I mean, one way to do it is the upfront, we don't have really upfront BTKI now, maybe in combination with BR is acceptable. If these patients relapse, give them a second line, even single agent rituximab is a second line therapy, right? You can even try that, and if they fail, they can take them to CAR T. So I think eventually they should get into CAR T at some point. But as we know, CAR T now is approved for all as third line therapy. So
yeah, absolutely. And I think with bendamustine, I have run into issues which, and it has now been proven that if patients fail chemotherapy and have received benda within 6 months of receiving CAR, their T cell yield is actually pretty low. So I typically try to veer off benda if I feel like I'm dealing with a high risk mantle situation, because if they were to relapse, I think the yield that we will get for their T cells might be low. But you cannot quite predict that timing anyway. So you talked about pirtobrutinib. Anything else that catches your fancy in the relapsed mantle cell lymphoma setting? You know, of course, a few drugs come to mind, but anything that you are looking forward to in terms of responses in relapsed refractory mantle cell?
I think I would like to see what CAR T does, the long-term outcomes of the CAR T, because to me, I think these BTKIs are all effective for a short period of time, but these are not going to be really permanent fix, of course, and not even to yield long-term survival outcomes, including pirtobrutinib, you know. So maybe the combination with venetoclax would be helpful, but I'm hopeful that CAR T and improvement in the outcomes of CAR T in the future would be the way to go.
Yeah, I think you're completely, I agree. Definitely for the audience here, you know, especially medical providers who are dealing with patients every day in and out. I think BTK inhibition certainly induces responses, but the durability of that response is not long lasting. So I think to be able to get these patients scanned frequently and to be able to take them to the next line of treatment is going to be very important. And then I think we have a question on the chat box here from Dr. Peter Forsberg. Is there data around single agent venetoclax in mantle cell lymphoma?
Yes, so there is actually. I should have probably incorporated it in my presentation, but there is a phase 1 study that not only included mantle cell, but all non-Hodgkin lymphomas. And they followed them up for up to 2 years and found that single agent venetoclax in the relapse setting for mantle cell, those patients achieved the highest PFS compared to the other subtypes of non-Hodgkin lymphomas. It was 82% versus 72 and 62% for other types of lymphomas. So yeah, it is one of the options, especially 2 years of progression-free. I think it's worth considering it, especially for patients that we don't have great options for, including TP53 mutated cases.
Right. And do you think we're ready for MRD? Do you do that in your practice?
I don't do that for my practice yet. I started doing it for CLL. I sent them to you guys because at Highlands Ranch we don't have that availability, so I have to contact you guys. I think for mantle cell it is going to be worth doing it. For CLL, I'm not sure, to be honest, up till now, although the data are showing that, okay, more MDR means more remission. But again, is the depth of remission important in CLL as it is for acute leukemia or mantle cell? Because still those cases that got, for example, ibrutinib in 2015 for CLL, that didn't have that deep of, you know, a response, but they still have a durable response of up to 7-8 years. So in CLL, it's questionable. Is it the depth of the remission or the durability of remission that's maintained anyways? But I think for mantle cell, I would start doing it.
And then in terms of overall, your frontline strategy, you showed very beautifully all the options that are currently available. And you also did say that your choice is to go with upfront BTK inhibition and to replicate what the Triangle study did. But say, for example, because of cost or reimbursement issues, you're not able to get a BTK inhibitor. And if a patient is transplant eligible, not TP53 mutated, you cannot get upfront ibrutinib. And if you now have chemo for you, would you take this patient to an auto transplant? I don't know. I have no answers right now because
so I would, I mean, ideally, yes, it looks like the previous studies have showed survival benefit, PFS benefit. We are only omitting auto transplant in the setting of ibrutinib. So ibrutinib seems to be the one that's basically, overriding the importance and the significance of transplant. But without ibrutinib, I would still take them to transplant.
Okay. So there's, of course, a lot of buzz with all the bispecific antibody data that was presented a couple of ASHs ago. So glofitamab and Mantle cell
I saw that.
look pretty good. So do you think it's going to eventually be a contender with BTK inhibitors or contender to CAR T?
Yeah, actually, I saw that. I really don't know before all the data are out, and but it could be. I mean, I think it's going to replace probably BTKIs for the second line therapy because they're obviously not really helpful. So I'm hopeful that is going to replace it, but I don't know yet. It will depend on the data.
That's great. Well, those are all my questions. I could take half an hour more of your time, but I will leave you unless the audience has any more questions. Thank you so much, Dr. Jasem, for a brilliant presentation.
My coughing and stuff.
Oh, you did great. And again, thanks everyone for attending our conference today. Have a lovely day. Bye-bye.
Thank you.